Good morning, everybody. My name is Ping Shi. I'm the PGY4 Neurology resident at University of Louisville Hospital. And my grand rounds topic today is Diabetic Radiculoplexus Neuropathy, which is a rare neuropathy in general. Okay, goals and objectives. So we will learn the clinical presentation, diagnosis, treatment, and the prognosis of DRPN. And we will go over briefly about the brachial plexus anatomy, and we will understand some basic concepts of EMG and its clinical correlation. And I will describe the pathophysiology and the update of DRPN management. Hopefully towards the end of the talk, we'll be able to determine when to consider plexus injury as a potential alternative localization for the unilateral weakness. So neuropathy, as we know, it is a very common neurologic problems because of high prevalence of diabetes, alcoholism, and renal insufficiency. And diabetic neuropathy is the most common complication in diabetes, and it is also the most common form of neuropathy in US. As you can see this pie chart, like in US, there are almost like 11% of people with diabetes, including 23% of them are undiagnosed. The prevalence of diabetic neuropathy actually significantly increased from 8% to 42% in diabetes after 10 years of onset. So we should know diabetic neuropathy is not a single entity, but a spectrum of different conditions that affect different nerves in the body. Therefore, we should be able to know the patterns and recognize the signs of different neuropathy and know the pathophysiology behind them. So this figure published in Nature in 2019 and shows us the spectrum of diabetic neuropathies. As you can see, figure A, which is the most common, and we call it distal symmetric polyneuropathy. It is manifest as stocking and blood distribution because it affects our lower extremity and hands, most common. And patients will usually complain numbness, tingling, pain, and needles in general. It affects the small unmyelinated fibers mostly, but it can affect large myelinated fibers as well. So it usually happens after 10 years of diabetes onset state. The second one, which is the one that I'm going to talk about it today, it is usually acute or subacute onset, and it is unilateral. It's symmetric. It depends on which segment of our spinal cord affected. It can generate different symptoms in the weakness in the legs or arms. If it is affecting thoracic, it can cause some like trunk issues as well. So it is called radiculoplexus neuropathy. Sometimes it can be caused by the glycemic treatment, hypoglycemic treatment induced neuropathy. Figure C shows a mononeuropathy, or we call it focal neuropathy. As you can see here, shows it affects the left median nerve and the right outer nerve and the right cranial nerve in this figure. Sometimes it can affect the cranial nerve as well, and cranial nerve 3 is the most common cranial nerve. Figure D is autonomic neuropathy, and the symptoms really varies depends on the organs involved. Patient can have some orthostatic hypotension, intolerance, arrhythmia, gastroparesis, constipation, diarrhea, and urinary incontinence, and they can have impotence and hair loss as well. Okay, the first and the most common ones, we call it like distal symmetric polyneuropathy. It is also called garden variety neuropathy. It has several features here. You should be able to know this. It usually affects more distally than the proximally. And the symptoms are symmetric. And patient will have predominant sensory deficits instead of very minimal motor or autonomic symptoms. Patient can have mild to moderate pain, and in general, it is slowly progressive. So on the right side, the figure shows osmium stand for myelin. You can see the three different neurofibers with this very little ones, and does not stand for the black or myelin. It is small myelinated fibers. If it is affected, the patient will have significant, some like painful paresthesias, and sometimes it have autonomic symptoms such as dizziness and syncope. And with the large one stand for the black, this is large myelinated fibers. It can affect our motors and the proprioception, vibration, and so on. And this very small, a smaller size, but myelinated, small myelinated fibers. Sure. Okay, so with garden variety neuropathy, we recommend blood testing for like as other peripheral nerve disorders. So this is from Continuous 2023. So those other lab tests that we can order. We can order a basic metabolic function panel with fasting glucose. You can order CBC as well, vitamin B, methylmalonic acid with and without homocysteine. You should order serum protein electrophoresis with immunofixation as well. Sometimes you can order NA and SSA, SSB. But if it is a variety, you're pretty sure about it, you don't need any additional laboratory testing. But if the patient has some risk factors on the right, showing on the right side, or clinical findings, such as the patient has some like GI symptoms or celiac disease, you can order some vitamin Bs and you can order anti-gliadin antibodies as well. But no, in general, you don't need any further testing like EMG or imaging testing. Okay. So for the atypical warning signs, you should also able to know that if it is this is in opposite to the garden variety that we mentioned before, if the patient has acute or rapidly progressive, this usually indicating the inflammatory, infectious, or toxic etiology involved. If the patient has more motor deficits than sensory, might concern some motor neuron disease. And if this patient has more proximal, like the shoulder or the thighs weakness, if it is symmetric, you might concern about polyradicular involvement, such as CIDP. If it is asymmetric, you might consider DRPN and or mononeuritis multiplexus. If the patient is positive for family history, you would order some genetic testing as well. So if you see any of these atypical signs, you want to do some further workup, including EMG and imaging usually is necessary. Other testing, it depends. Sometimes you can order CSF study if you're concerning like inflammatory, vasculitic, or paraneoplastic, or even inflammatory, even infectious. You can do lumbar puncture. Or sometimes if the patient has non-systemic vasculitic neuropathy suspected, you might want to do a nerve biopsy to confirm the diagnosis. So if you look back the literature, there are many terms regarding this diabetic radiculoplexus neuropathy. It was first described by Dr. Bruns and Dr. Garland at the end of 19th centuries. That's why it's first described called Brown-Garland syndrome. It is also called diabetic amyotrophy, proximal diabetic neuropathy, neuralgic amyotrophy, or sometimes parsonage-Turner syndrome. It depends. So the radiculoplexus neuropathy diabetic can affect the roots, the plexus, and even peripheral nerves. They are all reported that, and also DRPN can affect the cervical, the brachial, the thoracic, and the lumbosacral plexus, the different segments. And there is a retrospective study. They show the DL, which is lumbosacral radiculoplexus neuropathy and cervical peripheral neuropathy. They share many of the clinical and pathological features. So therefore, in my talk, I'm going to focus on DRPN. So DRPN in general, it is rare. It affects approximately 0.8 or 1 to 1% of percentage of diabetic individuals. It usually affects the elderly people, and on average onset is 60 years old. It affects more in male patients than in female patients. Usually they start with severe pain, the acute or subacute severe pain in the proximal limb, and then it can spread distally. The pain is often quickly followed by the weakness and paresthesia within days to weeks. The symptoms are usually unilateral at onset, but sometimes in some patients it may become bilaterally. It is in a non-length dependent and asymmetric fashion. It affects approximately 50% of patients. They have significant weight loss, and they will develop autonomic symptoms. The disease progression is largely monophasic, and the pain and weakness can actually persist from weeks to years. If you see the patient have recurrent symptoms, you will consider the hereditary form, which is called hereditary neurologic amyotrophy, which is associated with septin9 mutation. So just briefly talk about this case. So he is a 55-year-old female. He has history of hypertension, hyperlipidemia, type 2 diabetes. He denies any history of neck pain or any recent trauma. He presented ER with acute onset left arm weakness and severe pain. There are no associated autonomic symptoms. On your exam, you'll find the right upper extremity and bilateral lower extremity, their strengths are full. And on the left upper extremity, the distal strength, the grip strength, they are 5/5. The deltoid triceps and biceps, they are 3/5. Patient also complains of sensory loss in the lateral forearm, and the deep tendon reflexes are diminished in the left arm as well compared to the right side. And in the following clinical visit, you can see that there's significant atrophy in the left shoulder girdle muscles, the left deltoid and left biceps as well. And on his initial visit, his A1C is over 15%. And he was diagnosed with diabetes around 35 years old, and his CK is normal. So for this patient, he does have several atypical features that we mentioned earlier. So he has his onset is acute, and he more involved the proximal side, and the symptoms are symmetric. So this kind of fit to the second pattern, which is radiculoplexus neuropathy. Of course, in the ER, you want to rule out stroke first, and his MRI brain is negative. His MRI cervical, he also got MRI cervical, which shows C5 to C6. Shows some moderate right, then the left severe neurofibromatosis stenosis, which cannot explain his left-sided weakness, right? So we think probably it's not caused by radiculopathy. So when you're concerned about the plexopathy, you want to get detailed clinical history, and you want to do more detailed physical exams. So by the timing of the symptom onset, you want to know whether it's acute, subacute, or even chronic. You want to see whether the patient has any history of trauma, recent immunization, or some comorbidities such as cancer or radiation treatment. For the physical exam, you can do some special tests, just trying to pinpoint the lesions, such as you can observe whether the patient has any Horner syndrome, meiosis, ptosis, and hydrosis. If they're positive, they usually indicate CA to T1 level. You can also observe clavicle deformating, whether there is any fullness or any mass in the subclavicular region. And you can also simply just just tap or use your hammer on the supraclavicular fossa, just if the patient has reproduced the symptoms like pain or radiation, pain and numbness, it is Chinese sign positive, indicating plexus is involved as well. You can also check the back muscles, such as levator, scapular, rhomboid, because those muscles are innervated by nerve directly from the root level. So you can pinpoint the lesion as well. And you can also check the medial winging of the scapular as well. If you're really concerned about radiculopathy, you can do spurting test as well, okay? I will not go over the detail about this test. So this figure is kind of a little bit busy. On the left upper, it shows a dermatome. So I hope that everybody pretty familiar with the dermatome distribution. So for this patient, he complains of left lateral sensory loss. It's more consistent with and towards the fingers. So it's more consistent with C6. At least he probably has more involvement in the C6 level. And for this different joint movement, you can also kind of help you to pinpoint where's the lesion, okay? Such as the shoulder, elbow, supination, pronation, and wrist flexion, extension. The reflexes as well. However, we usually do the reflex in the tricep, bicep, and supinator. They're more like in the upper trunk, I would say. And on this figure, it shows you the differentiation between the damage, the symptoms related with the root only and peripheral nerve only. It's kind of busy. I will not go over the details about it, but in general, mononeuropathy will demonstrate more weakness than the root injury, because the muscles usually will be innervated by more than one roots. And also the root injury will involve more muscles, which are innervated by different peripheral nerves. Okay. So this figure I would like to go over briefly about brachial plexus, the anatomy of brachial plexus. So as we know, we have 31 spinal nerves, and it's C5 to T1. The ventral rami forms brachial plexus. As you can see on the left side, C5 to C7 roots, they run out of the spinal cord above the associated vertebra, while C8 and T1, they are running like above and below T1 vertebra. This is just somewhat that may help you to find where the lesion. And on the right side, this is probably we're very familiar with. So this is ventral and dorsal roots. They come out of spinal cord, join together to form the spinal nerves. Okay, it's a mixed nerve, including sensory and motor information. So C5 and C6, they join together to form the upper trunk. And C7, it will become middle trunk directly. And C8 and T1, they join together to form the lower trunk. So these three trunks, they divided further into anterior and posterior division. So all three posterior divisions, they join together to form the posterior cord, which is located posterior to the axillary artery. And two anterior branches from the upper and middle trunk, they join together to form the lateral cord, which is located lateral to the axillary artery. And the lower trunk will become the medial cord, I think. Yeah. And then after three cords, they will generate 5 terminal peripheral nerves. So the lateral cord will become the neuromuscular, musculocutaneous nerve, and the posterior cord will become axillary and radial nerves. And the medial cord, the medial cord and the lateral, they kind of join together to form the median nerve. So the median nerve is basically is from C5 to T1. And the medial cord, the part of it will become the outer nerve, which basically usually is C8, T1. Okay. And I would like to look a little bit detail inside the, close to the spinal cord. As you can see here, this is a ventral root. This is a ventral root, basically carrying the motor information, and its motor neurons is located in the anterior horn of the spinal cord. And this is a dorsal root, which carrying the sensory information traveling from peripheral to the spinal cord. And so different from the motor or the ventral root, the pathway, you should know the neurons is actually located outside the spinal cord. We call it DRG, okay, dorsal root ganglion. So knowing this anatomy is important to help us localize the lesion, whether it's radicular or whether it's a preganglionic or postganglionic. Okay, help you to better understand how to interpret the neuroconductive testing as well. So as you can see in the middle, for the neurodegenerative disease, you can have some disc herniation. It will pinch the nerve roots, right? However, due to the anatomy, some special anatomy, the DRG, which is here, most time it will be protected. It will be spared. So if we do the neuroconduction test, if you have a lesion such as radiculopathy, which is proximal to the dorsal root ganglion, when you check the sensory nerve transduction, you will get the normal testing. So if you see the norm, snap in your study, you can just safely draw the conclusion the lesion is preganglionic. Okay. And here's another anatomy picture. So I just want to show another important anatomy of the paraspinal muscles. Okay. So we already talked about it. The dorsal root and ventral root, they form the spinal nerve. As you can see here, it's a mix, the sensory and motor. It is very short. As long as it forms, it can split into two branches. One is dorsal ramus. Okay, dorsal ramus is going back to supply our back muscles. Basically, the paraspinal muscle and some sensory of the trunk as well. And the ventral ramus just is a brachial plexus or brachial plexus. It will just go down the neck and into the axillary and to supply our arms and hands. So for this anatomy, you should know the posterior rami, like here, which is kind of a root collaterals. It is distal. It is distal to the DRG, right, to the spinal nerve, but is proximal to the plexus formation. So therefore, when you do the EMG, the paraspinal muscle gonna be affected in the radiculopathy instead of plexopathy. Okay. And here are several nerves which are branched off directly from the roots before the plexus. So that's why when you do the physical exam, you want to check those muscle functions. If they are damaged or affected, that kind of give you a hint. This is some root damage. Okay. So there is long thoracic nerve which supplies serratus anterior muscle, which is come from C5 to C7 roots, and dorsal scapular nerve, which supply rhomboid and levator scapular, which is from C5 roots, and a phrenic nerve, which supply the diaphragm, which is from C3 to C5 roots. Okay, as you can see here. There's some nerves, they come directly from the trunk as well, but I will not mention here due to the time limit. So most of us are probably already rotated in the EMG lab, so we should know where you want to put those electrodes and where you're going to stimulate the nerves. Okay, usually we'll put the recording electrodes a little bit along the nerves more distally. Okay, the reference is even distal, more distal to the recording side. And the anode and the cathode is a stimulation side, and the cathode is more closer to the recording side, and there is a ground electrodes in between. Basically, the electrodiagnostic testing is an extension of your physical exam, and the purpose is to localize and to determine the severity of the damage. So on this slide, on the left side, basically you're doing the sensory testing for the left median nerve. You place the recording electrodes in your left second digits, as shown on the shown as a blue here. Okay, and you're gonna stimulate the nerve distally. With the stimulation, it will generate, the nerve will generate active potential, and the active potential will propagate distally. And it's got recorded here as shown this sensory nerve action potential with amplitude and the latency. We call it a snap. On the right side is a left motor neuron, left median nerve motor conductive test. You place the recording electrodes on your left APB here, and your reference is gonna be the tendon of that muscle. So different from the sensory test, you usually stimulate the motor nerves proximally and distally, the two sides. The reason is because for the motor conduct test, you record the muscles instead of the nerve. So you record the muscle acting potential. So from the nerve to the muscle, there are neuromuscular junctions and end plate in between, which will delay your transaction and slow the velocity. So that's why we do the two sides. We'll simply just do the simple math by doing the distance between the proximal and distal and divided by the difference of the proximal latency and distal latency, and you will get the real velocity here. So in general, the most neuropathies, they are axonal, which you can, it's recognizable by reduce the amplitude in SNAP or CMAP. And they will have normal or slightly reduced nerve conduction velocity. So reduction in amplitude indicating axonal loss, and increase the latency or reduce conduction velocity indicating demyelination. Okay, about nerve conduction test, the sensitivity and specificity. It has very decent sensitivity and specificity, and it is reported to be 70 to 80%. However, in some situations, it's not quite sensitive, such as we all know, small fiber neuropathy, right? Most time you will just get normal results. And also when you want to check the motor conduction function, you can only see the CMAP changes after at least 50% of axonal loss. So therefore, it's not a good test for the CMAP. That's why we need a needle study, okay, which just put the needle, inside the muscle to check directly the muscle activity. And neuroconductors is also good for stimulating the distal nerves, but for the proximal, it's very difficult to check. It usually uses very large amplitude to get the response, and will have a lot of interruptions. So it is not good for proximal neuropathy, such as radiculopathy or plexopathy. That's why you need the EMG part. So the EMG, basically we use the EMG to check the muscle activities at rest and with voluntary contraction, this two parts. It is the most important, probably the most important components of the electrodiagnostic testing for plexopathy. So for a normal and healthy muscle, which is innervated by the nerves, you should not see any of the magnetism of the muscle. The muscle should be very quiet at rest. However, with denervation, the neuromuscular junction end plate will be very unstable, and you're gonna see this abnormal regular discharges, such as positive sharp waves and fibrillation potentials. Okay, if you see any of them, that means patient probably have subacute or chronic denervation happening. And you also want to observe the muscle with voluntary contractions. You want to see how the recruitment is, and you also wanted to look at motor unit morphologies to see whether there's any acute or any chronic changes. So this figure shows you, these are the morphologies of the chronic denervation or reinnervation. Like this figure shows you there are 3 motor units, and in the middle, this motor neuron kind of have axonal loss, and it lost the innervation to these muscle fibers. So after a few months, with time going on, the neurons are close to this one. These 2 neurons gonna start sprout, and re-innervate these muscles. Okay, so this motor unit gonna innervate more muscles than itself, as well as this one. So with this re-innervation, you're gonna see with more muscle fibers, controlled by the motor neurons, you're gonna see the muscle unit acting potential amplitude gonna increase. You're gonna see it is very tall, and the duration gonna increase because it innervate more muscles, and they may not depolarize at the same time. So you're gonna see different phases. We call it increased polyphasia. Okay. Usually the recruitment you're gonna see the recruitment in the EMG very early. Okay. Decrease the recruitment very early, usually less than 2 weeks, and then you're gonna start to see some spontaneous abnormal activities such as fibrillations and so on. And then for more chronically, the spontaneous activity actually will disappear, and you will gonna see more morphology changes. So if we go back to this patient, his nerve studies, so we did basically on the first time we did basically on the left side, we checked the left sensory nerves and motor nerves. You see the decrease of the amplitude in the left median sensory nerve, and as well as the left ulnar motor nerves. So this provide evidence for axonal loss polyneuropathy, and there is not significant slowing that we found. And we also did the EMG part, and you can basically just almost all the muscles in the left side, and you can see this kind of abnormal spontaneous activities in almost all the muscles. Okay, and you also saw like significant decrease recruitment, especially in the biceps, triceps, and deltoid. That indicates more like the roots level from C5 to C7, or some upper and middle trunk involved. And we also did the cervical paraspinal muscles as well. It shows the abnormal spontaneous discharges as well, which indicate they might involve the roots as well. So this kind of confirmed our diagnosis in this patient. So we repeat the EMG in 9 months after the injury, which is more chronic. And for this time, you see more chronic changes with the MUAP morphology change. This is EMG done in biceps. You see this actin potential, which is all very, very tall. And we also see less spontaneous activities compared to the first time. So this indicating more chronic changes. The muscle has more re-innervation happening. And this is a deltoid, which shows you the polyphasic, but the amplitude is not as tall as a biceps. So this indicating the delta might be in the early re-innervation state. So for the imaging, as I mentioned earlier, MRI is necessary. However, the sensitivity is not quite good. So it's a range from 41 to 70%. And in general, when you do the MRI test of plexus, you will get the important results. However, we still order MRI because we want to rule out other differential diagnoses such as radiculopathy or compressive or infiltrative etiologies. So that's why we'll just go ahead under MRI cervical plexus. So as you can see here in this patient, so on the left on the top two panels, it is the coronary view of the STIR imaging, and you can see this significant increase of STIR signal in the upper and middle trunk. And you also see the enhancement in the left shoulder rotator cuff muscle, which can be a secondary to inflammation or denervation. If you look at in the sagittal view, you also see this increased STIR signal in the upper and upper and medial trunk, as well as a lateral and posterior cord in this patient. Okay, so the pathophysiology, so all the evidence, if you look at the literature, all the evidence is based on the nerve biopsy study. So, and also the subacute time course and painful nature, they're suggesting this is a process with a vascular or ischemic natures. So with those nerve biopsy study, you see these typical ischemic changes such as active axonal degeneration, multifocal fiber loss, injury, neuroma, focal perineural thickening, and neovascularization. And there are another mechanism proposed. There might be some disimmune or immune-mediated inflammatory process going on because they find the evidence of upregulating some inflammatory markers in the DRPN. There are some risk factors such as diabetes, definitely the risk factors. Others such as patients starting the treatment for hyperglycemia, or some immunization or infectious illness, or patient might have a recent surgical procedures performed. This can trigger this process. So this study was done in 2000, published in 2000. So this is a single nerve from the patient, okay? And from the left upper to the right lower, it's from the proximal to distally, okay? This is electron microscopy image. As you can see here, this axon is significantly enlarged, right? And it has demyelination, so you don't see any like dark signal around the nerve. And you also see this accumulated organelles. So they propose this might be the interference of the axonal transport by the ischemia. And also the ischemia will cause the axonal degeneration. I think it makes sense. And if you look further distally and on the left lower, you will see, so the axon becomes smaller and it's rarely myelinated. And you go further, more distally, you will see the nerve, they become a little bit larger and they are remyelinated. So this is kind of their repair mechanism. But the myelin is very thin compared to normal. And this was done in the same study. So they basically do the immunostaining in the damaged axons, damaged axon vessels compared to the normal region. So they stain the vascular smooth muscle with actin, which is shown here in the brown color, and then they counter-stain with H&E. And you can see here, compared to the normal region, the vasculitis region is, you can see this brown color, which is smooth muscle is separated by mononuclear cells. They're fragmented and they're displaced outwards and they decrease in amount. So this is the kind of typical changes of microvasculitis. So for the inflammatory immune cause, this is a study published in 2008. They basically do the immunostaining of different inflammatory markers. So this is intercellular adhesion molecule 1. You can see compared to the control group, the epidural vessels in the disease patients, they show significant elevation of ICAM expression in the epidural vessels. And this is done in the same study. Basically, they stand for another inflammatory marker, tumor necrosis factors alpha. This is a control, and from the B to F, they are DRPN patients. And on the top, in the B, it stands for the TNF alpha, which is shown as a brown color. And on the right side is macrophage. So they stand with KP1, which is a marker for macrophage. So they say they pretty co-localized. And on the lower panel, you see the D, this is brown, stand with TNF alpha. And you also stand the strong cells with the S100. And if you do the microscopy, they are co-localized as well. So this indicates, at least in Schwann and macrophage, there is a elevated inflammatory process, and there's no TNF immunoreactivity in the control group. So with those disimmune mechanism ongoing, you might wonder whether the patient is responsive to some immunomodulatory treatment. Actually, early studies, there are a lot of early studies they showed clinical improvement with either oral IV steroid or IVIG or plasma exchange. However, these data are limited because they either have small numbers in the study, or there's no control group to compare, and especially in a disease with natural history of recovery. So that is important. And also there are some later randomized trial, they found the pulse steroid therapy was not beneficial compared to the placebos for the functional improvement in diabetic amyotrophy. And also there is a systemic review in 2017, and they don't find the good evidence from the published randomized trial to support of this immunotherapy. So therefore, so far, the management of this disease is just supportive and symptomatic treatment. Of course, you have to have the strict glycemic control, okay, for the diabetes, and for the pain, it's the same. For other neuropathies with antidepressant or gabapentinoid treatment. You generally avoid opiate treatment. However, in some, you can use it for short-term pain relief if the patient does not respond to other treatment. For the weakness, the most effective intervention is the PTOT. The prognosis. Okay, the course of diabetic amyotrophy is variable. However, it is often gradual and incomplete restoration in muscle strength in correlation with aggressive glycemic control and those physical therapies. However, the majority of the patient, they will still have some like a residual weakness or decreased or diminished deep tendon reflex in the patella or ankle, and some exercise-related pain, the stiffness. The full recovery of the strength occurs only in 10 to 20% of the patient. So this is the algorithm to showing how to diagnose the diabetic radiculoplexus neuropathy, like very popular recently after 2 case reports. So basically it's what we talked about earlier. So if you see those warning signs or typical signs, you have clinical suspicion for DRPN, you're gonna just go to the 2 different pathways. One way is you wanna rule out other diagnosis to get from whether patient have any trauma or any inflammatory autoimmune, whether patient have any infectious or malignant process ongoing. The other side, you want just to check have the usual the labs for the neuropathy, such as A1. You definitely want to check A1C, and you also want to check some non-specific inflammatory markers such as CRP, ESR. You want to do the neurophysiology testing, nerve conduction test, and EMG. You also order MRI. The CSF study here, they said it's not essential for the diagnosis. So with this negative workup and more supporting findings from this pathway, the patient also, the symptoms cannot be explained by an alternative diagnosis, you will diagnose the patient with DRPN, basically. So the future directions. So so far there's no biopsies in the plexus because this disorder is not fatal. So generally they won't do any like biopsy of plexus. It's not justified. And also there's no very supportive evidence for the disease modifying treatment for that diabetic neuropathy remains elusive. So I think there should be more studies to be done in future, just to check whether there's many more specific markers or pathophysiologies behind it, so that it will further direct our future treatment for this disease. Okay, just before the end of this lecture, I'll give you a summary. So DRPN, it has acute and subacute onset of asymmetric pain and weakness. EMG and MRI is necessary to confirm the diagnosis and also rule out other etiologies. CSF study or peripheral nerve biopsies usually is not necessary for the diagnosis. And so far, the treatment is supportive, and there are more studies need to be done for the mechanism behind it, which could direct our future treatment. So with all this, thank you so much for your attention. And I would also give my special thanks to Dr. Brown for the EMG data and also the integration. Right. With all this, any questions? Yep.
This might be a stupid question, but does it always have to be painful? Can it ever be painless, or have there been cases where it's been in the past?
Yeah, just from the literature, it's not necessary always to be painful. There are like non-painless weakness patients, but it's not. But pain is usually more often. Yeah.
So for controlling diabetes, how slow should these primary care physicians be, or how aggressive should they be trying to reduce the A1C without causing treatment-induced neuropathy?
That's a very good question. Actually, I didn't look more literatures about the treatment-induced radiculoplexus neuropathy. But I wouldn't see there is much difference for that because it really depends the accident.
So we did a review that the A1C that goes from 14 to 7 in 3 months is a really high risk for causing this treatment-induced neuropathy. It's like
like 50%.
Yeah, that's like the more severe treatment-induced neuropathy, diabetes seen with the sharper drop. I think there was a number like don't drop the A1C by more than 3 points. It's like maybe 1 point per month, 1% per month. If you bring it down from 14 to 13, 12.
How about those people presenting all these things?
All the people, yeah.
How rapid
the CGM, and all of a sudden,
all of a sudden they have neuropathy.
It happens that neuropathy is, fortunately, that neuropathy is reversible usually, and it's just confusing and frustrating for someone who's getting the diabetes under control to have the induced type of neuropathy. And in the old literature, that was one of the explanations or potential causes of this diabetic amyotrophy or this the neuralgic amyotrophy was people who corrected their glucose, corrected diabetes too quickly. If you look way back, there's things about see if someone they got their diabetes under control all of a sudden this or after that. Your question about pain is not necessary, but if the pain is kind of the biggest prominent feature of this, these people will go to the emergency room if the pain is that severe. They don't stay at home. Problem is, they go to the emergency room and they get the medications and they get the MRI of the C-spine or the lumbar spine, and we don't see them until maybe 4 to 6 weeks later. And if you can imagine another monophasic condition, GBS, Guillain-Barré, if you can imagine if people were sent home and come back to see you a month later, what kind of treatment is going to help a month later? It's something that if you get called from the emergency room about a patient who has this really intense pain actually the pain is there before any weakness, before any kind of other neurologic symptoms.
Right.
And so a lot of times neurology doesn't get called. So it's almost like you need to share this with the ED because they're going to see this and they're going to, it's just such an intense pain, stabbing, deep, intense pain. And humans being humans will come up with something, well, 3 days ago I did this, so it must have been that. And people will try and figure out, what did I do? What happened? I just had this vaccine, that's it. Or I just had this surgery last week, that must have caused this. But it is so severe that people will kind of rack their brains to try and figure out what was the underlying cause. And usually it's just, if we could capture these patients a little bit sooner, I think some of that data that we have, a lot of those studies, I think, were probably after the diagnosis, which is usually delayed. And so
Right.
the inflammatory part might have run its course. So just if you get the story of something with the arm or the leg, onset of this severe pain, not really in the neck and not really in the back, but kind of off to the side, this should be out of this possibilities. Thank you for
Right.
thank you for choosing. You're a muscular topic. It's my favorite.
My favorite as well. Okay, any other question?
Mentioned like there was
Yeah.
like there could be a microvascular component. Do you guys see, and I know this is a presentation, other variants, LDL, hypertension, like diagnosis, control of these things? Or was it purely just a,
So like the other, because I'll sometimes tell people it's kind of like a stroke of this.
Yeah, it's like
plexus. And so we should be checking all of this. We should do the code stroke.
I think it's a small thing to be able to check those labs and probably control weight loss, hypertension.
Right.
I think that
It's a good question.
the mechanism behind diabetes induced microvascular ischemia is different than hypertension
And the stroke, yeah.
radiculoplexus.
So yeah, the literature says like this kind of diabetic related radiculoplexus neuropathy. I think that the diabetes itself or those risk factors for stroke, they play a relatively minor role compared to other, mechanisms like autoimmune or some inflammatory things ongoing.
So they wanted to treat it with Parkinson's too?
If the patient, they say like if the patient is really severe and has a lot of pain and it's very difficult to treat, you might consider some steroids. Yeah, but the evidence is very limited.
Yeah, right.
Yeah, I think the
So it's also similar to bowel palsy, where the evidence for prednisone or steroid is, if you get it early, it's a little better. But if bowel palsy gets diagnosed a week later, not really much reason to do that. I don't think there's an infectious. Oh, did you see anything about hepatitis E?
for this.
Yeah, so if you see this, check to see if hepatitis E, so hepatitis E does not cause, usually doesn't cause hepatitis in normal people, but it might trigger the immune system to cause some other problem.
It could be. All right, guys. Thank you. Thanks. Huh?
2 minutes to spare.
Yeah. Good time. Oh, so. What? Where are those? Where?
No.
Well, yeah.
But this thing. Thank you.
I mean, it's a little bit dense, but it's okay. See?
Sometimes.
Thank you. Thank you. Thank you.
Sorry.